Now, I'm going to talk about robotics, Mako, and basically it solves every problem they've discussed this morning. So you put a robot in, it's all solved. Clearly I'm joking over that, but it really can help you in some of these difficult decisions. So I work in Abu Dhabi, introduced in Mako in 2013 when we designed the Trident 2 acetabulum, which I don't think is released yet in India, but I'm sure it will be soon. I'm an early adopter, so I like technology, and Mako is that technology that early on we used, and I've watched it develop, and it's improving, and it's going to continue to improve. I think over the next few years it's going to blow you away. I've already been in the States a few weeks ago and was looking at the revision options with Mako, both for the knee and the hip. It's really exciting, and I think it's going to really help with the revision cases. And then when you add in AI and decision making, these robots are going to be able to look at databases of what's the best evidence in terms of which protocols we should follow during surgery, and they'll be able to nudge us and point us in the right direction while we're actually doing the surgery. So it's going to be a really exciting future for us. Mako has got marketing value with it. Since I started doing Mako in the UK, really rapidly we had massive referrals. The number of cases that I did in the hospital shot through the roof. We hit our targets. This is a target 500 hips, and it's really successful and continues to be successful. My preference is Accolade 2 and Trident 2, and in difficult cases or the elderly, I use Exeter. The Accolade 2 hip is probably going to be slowly moved out for the new Insignia. So for people who do DAA, it does have a collar, it's fully coated, and that will be hitting India next year. It's hitting everywhere outside the USA next year. So look out for the Insignia hip. Preference in Mako, express workflow, it's quicker. CT planning is just awesome. It helps overcome so many of the problems we've discussed this morning: leg length, offset, center of rotation, everything. Virtual range of movement, we've talked before about this, position of your acetabulum. You can pre-operatively plan, you can change the position of the acetabulum, and then you can put the hip through different range of movement, and you can see the little red area, posterior aspect of the acetabulum here, which shows impingement. So you can virtually change the position of the cut, put it through the range of movement, and it prevents you having that impingement in the operation. The haptics. The haptics is a really good option to keep us safe. So when we're reaming, we know we're getting to the floor that we've already predicted on the templating. It keeps us in this tunnel where we don't go superior or too far medially. It's a really good system. And it also guides us when we're putting in the acetabulum. So as we're hitting in the acetabulum, it will guide us exactly how many millimeters we've got to go in, and I'm sure that the presentation of surgical approach will show you that. Now, we talked before about spinopelvic association, and if you've got patients who've got instrumentation of the lumbar spine, or they've got severe osteoarthritis or ankylosing spondylitis, then the Mako can help you with this. We talked about sacral slope. It's the easiest measurement to measure. We know that as the patient sits down, the pelvis tilts posteriorly, and as you get the posterior tilt, you can see on cup version, the Mako will show you that in the supine plan position, that's the CT position, cup version 20. In the standing position, it's slightly anterior tilt with 18 degrees, and as the patient sits, it goes to 32 degrees. So that 32 degrees of inclination makes the hip safe in the seated position. If you have a stiff spine, it won't be in 32 degrees, it might be in 18 degrees, and you've got a higher risk of dislocation. So that it doesn't tell you how you should put the hip in, but it gives you an indication that there might be a problem in that patient, and then you can change the version as you see fit. So a couple of examples. This is a patient who had subtrochanteric fracture. I've shown this example because you can see the extreme leg length discrepancy. So you've got 14 millimeters shorter, offset was 11. What we try and do in this case, we're going to try and balance the leg length. You can see on the x-ray from the CT that it's really good around metalwork. You can get good pictures, accurate pictures around metalwork. We go through the acetabulum, which is straightforward here, do our planning. We can see how the acetabulum is going to look on the CT scan, and that's really representative of what we'll see in the operation. Then we can reduce the leg length. So the box on the left at the top is 0, so we've recreated the leg length. I've decided to keep the offset the same. I think that's better not to change the offset. And then we can perform the operation. So there we go. Happy patient. Then if you've got more complex patients, like this patient actually came to see me in Abu Dhabi from India. They've got complex hips here. He was complaining of a lot of pain in his hips, very poor mobility, couldn't sit comfortably, couldn't stand. We assessed his spine, which was normal. Spine surgeon saw his spine. I put the hips through the CT scanner for the pre-op planning. I thought it'd be interesting to see, and you can see just how complex the acetabulum looks in this case. There's very little bone in the acetabulum. The green area shows the center of rotation of the acetabulum, and then magenta is an anatomical center of rotation, all very bizarre looking. We can see here that even with the smallest accolade stem, it's very tight canal there, difficult to improve the leg length. You've got a retroversion 42 degrees, so very abnormal hip. With the planning, we can see I was planning to lengthen the hip 47 millimeters and increase the offset there. And you probably know how these hips look: flattened femoral head, really flattened acetabulum. So we went on to use Mako, but I've used SROM hips in here because we had to do trochanteric osteotomy. It took 4 centimeters from subtrochanteric osteotomy in both hips to gain the leg length. But it was the Mako pre-op planning that really helped me in this case. It helped me realize what I could achieve with a simple uncemented prosthesis. And then thankfully the osteotomies have healed well and the patient's doing very well. So with my experience of 1,000 cases when I left the UK, patients are happier. They really do recover quickly. They go home same day if you want. Again, I agree with the other presenters. I would prefer my patients to go home day 2, day 3. Younger patients get full activity. They can do anything really. Post-operative appearances are consistent. I've not had a single leg length issue. And I don't give any of my patients post-op restrictions. I just say, if it feels okay, you can do it. Thank you very much.